Thank you very much, Marco. So after having 2 lectures by Professor Turner and Professor Andruela, now we're going to talk about epilepsy. And as Professor Leonardo said, it's an easier topic. I'm going to show you it's not. Okay, easier than. So, first a little bit about the history. Epilepsy is, of course, a disease that have existed for many years. And already back early in the 19th century, Jackson was actually the first one who noted that ictal symptoms could be correlated to anatomic locations of cerebral lesions identified post-mortem. And also a guy from Glasgow, William McEwen, was a neurosurgeon that already back in 1970 performed the first successful surgery for an intracranial lesion that was located by ictal symptoms in the patient. So, epilepsy is a common disease and common brain disorder that occurs in the United States in 1 to 2% of the population, which is approximately 2 million people. In Sweden, we have at least 60,000 people, and 10,000 of them are children, and we have a population around 9 million. So, we are there, around 1–2% of the population has epilepsy. In this group of patients with epilepsy, seizures becomes intractable to medication, and they become so-called refractory epilepsy in 25% of these patients. And that is a problem because both financial, economical, and has social consequences, not only for the patient, but also for the family and for the patient. If he's in an age where he's working, he could have difficulties maintaining a job because of his seizures. If you're a child and you have medical refractory seizures, you will be developmentally slower, you would have problems in school, and it would affect your education. Because if you have repeatedly seizures like 10, 20, 30 times a day, you could imagine how difficult it is to live a normal life. So these are the group of people that we need to try to help. And the causes for epilepsy, we have the general known causes that we all can see. For example, here I just show you a couple, and that is like a tumor. You have a vascular malformations, or you could have congenital causes. These are the so-called known causes, together with stroke, previous infection, trauma, or, as I said, congenital. Then we have the cryptogenic causes. And these are the causes that we might be most interested in as neuroradiologists, because here is where imaging comes in, very handy. And these are the presumed but not identified lesions. And finally, we have idiopathic causes for epilepsy, where we do not have a known cause, and we don't find anything with the help of imaging either. When it comes to the epilepsy imaging, it have now developed lately in the last 10–15 years. And as we all know, CT and MR of the brain are now routine for evaluation of patients with refractory epilepsy. And also, and here I would like to point out, and I'm going to do that a couple of times, that the approach when we deal with patients with medical refractory epilepsy is actually a cross-sectional approach. That means we include psychology, we include neurosurgeons, we include neurologists, and so on, and not just an imaging thing, because we all together need to try to come close to the diagnosis and help to find a lesion that can be surgically removed, and the patient might be seizure-free and helped. So it is a cross-sectional approach, and that is the approach we have to take when we are dealing with these patients. So, what is the goal of the imaging itself? Well, for the neuroradiologist or for the imaging people, it is to find the lesion, to detect the lesion or the lesions, because there could be more than one, so that these could be surgically treated. Also, imaging is helpful in the workup of seizures and to follow a patient that is treated, that maybe they had a surgical resection and he was seizure-free, and then suddenly he becomes having seizures again. Then we know there must be another lesion, and then we have to go back to the imaging again, or even re-image the patient to try to find that second lesion, so that he could maybe have another second surgery and become seizure-free. So when we have once shown one lesion, doesn't mean that imaging is excluded for the rest. We might have to go back several times, change our protocol, do cervical imaging, and I will show you that, how imaging could be helpful in many ways. when it comes to the new onset seizure, and now we are talking a person who has his first seizure, a single seizure that has usually do not require any medication. That is something to remember. Secondly, if you have a patient who has his first seizure provoked by an acute event like a trauma, it's very unlikely that that patient would have seizures again. Also, if you have a patient who comes with his first seizure at the time where you have a disorder that damaged the brain, there's a much higher likelihood that this patient would have seizures again. And fourthly, if the patient has a first unprovoked seizure, the occurrence risk is much higher, up to 30–50% within 2 years. What does this tell us? It tells us that the history behind the seizure is extremely important in the workup of the patients with epilepsy. Because if you have your first seizure in an acute setting, that might be okay. It's not going to happen again, and you could calm the patient, you can calm the parents, and so on. But if it is an unprovoked seizure, you know that the likelihood of this occurring again is much higher. And that is maybe something that the patient should be aware of. So how are we going to image a patient who has his first seizure? There's a lot of debate about what to do. Are we going to do a standard protocol, or are we going to do high-resolution MR? I would say we should do CT first, in many cases. Because with CT, you will still be able to pick up the basic known lesions, a tumor, a stroke, maybe infection, if there's a congenital abnormality. So maybe a CT protocol is the first thing to do. And then, if you go further, then you could decide to do a routine MR of the brain. And the high-resolution protocol that I will show you should be saved to those patients who has medically refractory seizures. Reason is, it's a long protocol, takes a long time in the scanner, and it gives you more than 1,000 images to look at. And it has to be in this approach together with the neurosurgeons, neurologists, and psychologists if there's going to be any value to it. So, CT or a standard protocol of MR protocol, you could start with that, and then from there you will go to the high-resolution MR. Back in '97, the International League Against Epilepsy and Neuroimaging Commission recommended that all patients who has medically refractory epilepsy should have a high-quality MR of the brain, which is then a high-resolution MR, temporal lobe epilepsy protocol. A study that was done in England like 8 years ago on 700 patients, in that protocol they showed that 250 patients had no imaging at all. 250 patients had a routine brain or CT, and only about a third of the patient had a high-resolution MR. So even though that is the suggestion, it is not applied everywhere, but hopefully in the future it will be, and especially now when there is an increase of epileptic centers, both in Europe and as well as in the United States, where we have this broad approach, including surgeons and neurologists, the high-resolution protocol becomes a routine. And why do we do the high-resolution protocol? First of all, we would like to identify a structural lesion, but we also want to see if we could find secondary lesions that might be distant from that initial epileptogenic zone. We use it to guide treatment management and to guide the neurosurgeons how to operate, not how they should operate, but where the lesion is and what kind of approach of operation they should do. And we could also use this as a predictor of clinical outcome or surgical outcome. The high-resolution temporal lobe epilepsy protocol is quite extensive, as you can see here, and includes the routine T2, T1 weighted images, the FLAIR, which is very good to look for signal abnormalities. In addition, you should have a thin slices MPRH or 3D sequence where you can look in coronal, sagittal, and axial plane, and you do one sequence with contrast. And then you could sometimes do diffusion or diffusion tensor imaging. Overall, it's over 1,000 images to look at. So it's pretty time consuming, not only to scan, but also to look at these images. And you need to look at all of them, and I will try to show it. Some of this here now in the lecture, and we will do some more of it in the workshop, how important it is to look at all the images. Here is just an example of how this temporal lobe epilepsy protocol look at. So you have the sagittal, you have your diffusion weighted images, your flare, your post-contrast coronal, then you have your high-resolution coronal, T2 coronals, and the flare coronals. So we have quite a lot of imaging in coronal projection, and the 3D you could then reconstruct into axial and sagittal, and you should always do that when you use this protocol. I will now go into two specific entities, and we're going to talk about refractory mesial temporal lobe epilepsy first. And again, when we come to this, I want to go back to this, I'm going to say this several times, the importance in the pre-surgical evaluation of patients with refractory epilepsy is to combine the group of people and carefully go over the patient's history and family history, as well as the kind of serology and what kind of seizures the patient actually has, and the risk factors. Usually patients also have EEG monitoring, and that helps us to locate the side where the epileptogenic foci could be. And then you also do neuropsychological testing, neurological testing, and speech evaluation. That also helps you in the evaluation of where the focus is and how it's going to be treated. And then we have the imaging, all this together to get the puzzle. So, mesial temporal lobe epilepsy, it usually is an acute insult to the mesial temporal structures, followed by a progressive change and gliosis in that region that you usually could see with an increased signal on the flare. And you will also have associated findings that I will come back to. There is, when you have reviewed the patient history, that is a very high incidence of complicated febrile seizures that have been reported in up to 50% of the patient who has mesial temporal lobe epilepsy, that they had these febrile seizures, complicated such as child or infants. The typical type of seizure is a complex partial seizures with characteristic auras. And the good thing with mesial temporal lobe epilepsy is that if we find it, it's surgical treatable, and the patient can become seizure-free. So complex partial seizures includes impaired consciousness. You could have déjà vu sensations. They usually have some rising epigastric sensations coming from below going up. There could be motionless staring, automatic movements of hands and mouth. They could have altered ability to respond to others when they're talking to you. You can have unusual speech or unusual behavior. Here is just the hippocampal anatomy, and you can see this drawing, and this is the region where you would quite often have hippocampal sclerosis. This is an image done by Professor Nadich at Mount Sinai on a 9.4 Tesla scanner, and you could see how nicely you could see the anatomy on a 9.4. Well, this is not something we use in daily practice, so we have to rely on a 1.5 or maybe a 3 Tesla if we are lucky. What are the imaging features of mesial temporal sclerosis? Atrophy of the hippocampus and or the amygdala that you could easily see on the T1 weighted images or on these 3D SPGR sequences. And very often you could actually see that visually. You don't even have to measure. You would have hyperintensity signal on T2 and flare due to the gliosis within the hippocampus. And secondary signs that you will see is atropic ipsilateral fornix and mammillary bodies. You would have an enlargement of the temporal horn due to the atrophy of the hippocampus, so there is more space for the temporal horn for the CSF. And you would have sometimes a general loss of the temporal lobe, so that you would have a little bit more prominent sulci. MRI are sensitive in up to 90% in cases of mesial temporal sclerosis, but not all. I'll show you that. Here is just a very classic pattern of a mesial temporal sclerosis, and you could see here with the increased signal in the left. Sorry, I'm going to go back. In the left hippocampus, and a reduced volume of the left hippocampus compared to the right side. And if you did a study was done back in '94 by Jack and his colleagues, and they found that visual analyzed could detect 85 to 90% of the atrophic hippocampi versus 90 to 97 if you do quantitative measurements. So in most cases you will be able to see that there is a atrophy of the one side of the hippocampus. And that is the classic hippocampal sclerosis. It is atrophy combined with increased signal and T2 and FLAIR, and a slight enlargement of the ipsilateral ventricle horn. Now we come to the atypical cases. Here is an example. We have a 43-year-old male with a left temporal lobe epilepsy. Could you see? Well, we see, of course, if we are looking here, we could see that it looks like the parts of the hippocampus is reduced in size. But he also has some abnormalities here in the temporal region, in the cortex, in the temporal region, very tiny, but still they are there. So this is more complicated than just the hippocampus itself. And you could see here, if we look at the FLAIR images, again, you see, yes, he has signal abnormalities in his left hippocampus, but these signal abnormalities do not stop there. This is tricky to make it short here. You see how they extend into the temporal lobe, and that is important because if you now would tell the clinician that he has left-sided hippocampal sclerosis, the surgeon will operate and they will do local amygdala hippocampectomy, and this patient will not be seizure-free. So he needs a complete different surgical approach. He needs a left temporal lobe resection to become seizure-free, because you need to get rid of not only the hippocampus, but also the inferior aspect of the temporal lobe for him to be seizure-free. So this is a more complicated, this is what we call the hippocampus plus. That is hippocampus plus additional involvement on the same side. Here's another case, a 36-year-old male with left temporal lobe epilepsy. And here you could see that the hippocampus on this side is almost larger than on the other side, with associated signal abnormalities. And that is what we call atypical hippocampal sclerosis, is when you have a hippocampus that actually is enlarged combined with signal abnormalities. And if you didn't have the signal abnormalities, it would be easy to maybe say that the right hippocampus was the one that was affected. So here it becomes important to have the clinical history and know where the patient's seizures comes from. In this case, they did a selective amygdala hippocampectomy of that lesion in the left side, and unfortunately, the patient didn't become seizure-free after that. And that tells us that most likely this patient has a second lesion somewhere that was not detected initially, and now the patient has to go back to imaging and maybe again surgery to become seizure-free. Here's another case, a 45-year-old male with NF8, and he has temporal lobe epilepsy. And you could see, yes, he has atrophy of the right hippocampus, enlargement of the ventricle horn, and signal abnormalities on the right side. Here's another patient, a 47-year-old male with history of meningitis and history of seizures at the onset of 12. He had his meningitis at the 18 months, and then he started having his seizures when he was 12. And again, you could see there is an atrophy of the hippocampus on the right side. And we are looking at his FLAIR images. There's signal abnormality, especially on the right side, and enlargement of the ventricle horn on this side. Now, this patient was a little special because if you look at his epilepsy, his semiology, you can see that he has two types of epileptic fit. First, he had head version with clonic movements of the head, and he has an aura of feeling odd. But then he also has simple partial seizures with blepharospasm, eye fluttering, and photophobia. So he has two types of epileptic fits. The EEG was localized to the right temporal lobe. The SPECT was also showed right temporal lobe hyperperfusion. But we went back to the images again, and if you look very careful on these images, there are actually two lesions. One we have already seen, that was the one in the hippocampus. But on the second image and on the third image here, there is another lesion. It's very subtle, but it's there, and I will show you it on coronal as well when it becomes a little bit more clear. But you see here, there's a second area of abnormality, slightly increased signal. You don't see the cortex as well as you see on the left side. You see here again? Very subtle. And that fitted much better with his epileptic, this simple partial epilepsy with eye flooding and photophobia. It was in the occipital region. So we went back and looked on the SPGR, and there is a little bit of irregularity. The cortex is not as smooth, you can see here. It's a little bit smoother than you expect. There's the lining between the white matter and the cortex is a little bit smooth, not sharp. We look at the flare, and again you could see in the same region there's a slight increase in signal and a little bit of irregularity here in the same region. And then they did a repeated SPECT, and now they could also show increased activity in this region. So what happened? Well, they did intracranial monitoring because they wanted to see from what area did he actually have his seizures. So they placed one in the temporal lobe, and they placed one grid in the occipital lobe. And there was epileptic discharge from both these areas. And this resulted in that this patient had 2 surgical resections. They resected the part of the occipital lobe, and then they went in and did a resection of the right temporal lobe, tip of the right temporal lobe. And this patient is now seizure-free. And the pathology that they found was that this patient had severe cortical dysplasia in the occipital lobe. And in addition, he had significant gliosis, extensive gliosis in the right hippocampus and temporal region. So he had dural pathology, and that is another version of the atypical hippocampal sclerosis, is those with dural pathology. He was left with a little bit of hemianopsia, which was understandable after resection part of the occipital lobe, but most likely he could live with that compared to have epileptic fits all the time. So, the spectrum of hippocampal sclerosis. Classic hippocampal sclerosis is volume loss and increased signal in the hippocampal formation as one lesion. Hippocampal sclerosis plus, then you have lesions in the hippocampal formation, plus more extensive changes in the temporal lobe, or you could sometimes even have it bilateral. Dural pathology as this one, you have hippocampal sclerosis or hippocampal sclerosis plus another active or inactive lesion elsewhere in the brain. And then you have atypical hippocampal sclerosis with signal changes and enlargement of the hippocampal formation on the one side. So here is the hippocampal sclerosis plus again. You see the signal abnormalities in the hippocampus and the temporal lobe. And there is no difference in the seizure-free outcome between patients who has ipsilateral hippocampal sclerosis or hippocampal sclerosis plus if you do a temporal lobe lobectomy. But if you only do amygdala hippocampectomy, you would have a patient that still would have seizures because he has lesions in the temporal lobe. If you have bilateral hippocampal sclerosis, you are in trouble because they cannot operate both sides. So you will remaining having some seizures. So then they have to decide which side is the worst. Okay, then we have those associated with dural pathology, and that is actually occurring as much as up to 20%. So anytime you see a patient with hippocampal sclerosis, you have to look very carefully for the second lesion, because up to 20% of the patients would have a second lesion. And most commonly that would be cortical dysplasia or malformation or cortical development, which is the proper word, gliosis or a porocephalic cyst. And if you remove both lesions, of course you would have a much better clinical outcome. So, a few words about cortical malformation or malformation of cortical development, or what we also quite often call cortical dysplasia. Development of cortical malformation can occur in several stages, from the neurons extending from the matrix going all the way up to the cortex. And this was described by Barkovich approximately 10 years ago, and this is his list. So you could have malformation due to abnormal neuronal or glial proliferation, which could be focal or multifocal. You could have malformation due to abnormal neural migration. And you could also have malformations secondary to abnormal cortical organization. So in other words, you could have anything from down here through the migration up to the organization within the cortex. That is, the cortical malformation can occur in all these stages. So some example of what we will call malformation of cortical development. First of all, we have nodular heterotopia, which means that you have gray matter in places where it shouldn't be. One classical location is adjacent to the temporal horns in the trigone region. And the problem with this one is that if you're not looking carefully, you could mistake it for being the hippocampus. But it's away from the hippocampus and is associated closely to the temporal horn. Then you could have band heterotopia, which is a more extensive heterotopia, and you could see it here, going along. You could have polymicrogyria, which is a failure of the organization at the cortical level. And as you can see here, this is polymicrogyria on this side, more normal on the other side. And you could have focal cortical dysplasia. I said you could have general, but you could also have more focal one. As you can see here, where you have a focal area of gray matter, it's like a little bit blurry, a little bit diffuse. The cortex is thickened compared to what it normally would look like. And then we could have what we call other focal malformation of cortical development. And this is one such case where you actually have thickening of the cortex and irregularities in the left temporal lobe. And then you see it on the FLAIR images that is an increased signal. And something that otherwise are normally unusual is that you actually have pathological contrast enhancement. This is not normally. So this is very difficult to differentiate against any kind of low-grade tumor just because of the enhancement, which is normally not seen in cortical malformations. And here you could have a very subtle, just blurring of the gray-white matte junction. Very subtle changes, as you can see here. And I will come back to this in the workshop, how we are doing this kind of imaging where you actually can get so good view of a part of the brain by using different kind of surface coils. So, despite everything we do, there are still patients that we do not find the lesions initially. And our goal is to find that one way or another, so we could take additional imaging modalities to try to help us. And what we can do is doing volumetric measurements, and that we should do by using these multiplanar reconstructions. I said that hippocampal sclerosis, you could most likely visualize that in 85% of the cases, right? But if you do not, and the patient has typical symptoms coming from one side, you might actually have to sit down and do volumetric measurements to show that one hippocampus is slightly smaller than the other, so that they maybe then could do surgery and help the patient. You can do the surface coil imaging, usually a knee coil or a shoulder coil, place it over the region specifically where you do think the lesion is located based on your other additional findings like the EEG, the SPECT, and so on. We can do MR spectroscopy. Some people are trying diffusion tensor imaging. By do co-registration, that would help you to find maybe the area where you have the epileptogenic zone, and then you go back again and look at these images very carefully, and you maybe will then see those subtle findings that you do not see when you look at these 1,000 images for the first time. But if you go back and look specifically at a region, they might pop up to you. fMRI can be helpful sometimes prior to surgery to see how it will affect maybe the movement of the hand or the foot or something like that. And of course, the higher field you use, the better it is. We don't use 9 Tesla, we don't use 7 Tesla, but maybe by you doing a 3 Tesla, you would come a little bit further than you would do on a 1.5. And by doing all this together and adding on all the other information that you get from the clinicians, I think there's a higher possibility that we will recognize the lesions and we will help to make the patient seizure-free, which is actually what the goal is. And if we are able to find the lesion, the likelihood that the patient will become seizure-free after surgery is so much higher. Like, for example, in this study, that 49% of the patients became seizure-free after finding the malformation cortical development, and additional 43% had significant improvement. That means nearly 90%. Compared to a patient that there is no visible MRI lesion they couldn't find, only 20 to 25% of the patient will be seizure-free if they have a surgery just based on all the other criteria, not imaging included. So finding the lesion is crucial for making the patient seizure-free. And this is just to show that you could then use MR spectroscopy, and if you do, you would place a single voxel or a 2D CSI in the location of the temporal lobes and compare the data on both sides. Here's just an example how it could look like. And what you normally would see would be a decrease of the NIA, N-acetyl aspartate, which is a marker for the neurons. That will decrease on the side where you have some pathology compared to the opposite side. If you only have one-sided pathology. If you have dural pathology or bilateral hippocampal sclerosis, you're not going to be helped. So again, I think I've emphasized this enough, but I still want to do it again. This requires a multidisciplinary approach, and you have to be aware that you speak with your clinicians and ask them, what is the problem? What kind of seizure does the patient have? Do you have any EEG that suggests the side? Do you have any other SPECT data that will suggest the side? And so on and so forth. Do anything you can to help your colleagues or the clinicians and to help the patients to become seizure-free. And hereby I will just finish up by saying I've tried to review some of the temporal and extratemporal causes of refractory epilepsy. We will have more on the workshop where you will be able to now show that you now know how to find them. I have tried to show the importance of the imaging in the whole setup, and also that we need to work in a group if this is going to work. And hereby I'd just like to thank my colleague Diana, who is my epilepsy colleague back in Ann Arbor, for giving me some of the slides that you have been able to see today, and I would like to thank you for your attention.